Hi, and welcome to yet another episode of Care Conversations, powered by Equipo Health, where we will be demystifying theories that you have heard about healthcare. And while we do that, we'll be bringing you pathfinders, people who have revolutionized healthcare in the US. So, if you remember, last time we had brought Romanus Joseph and Rafael Alvarez to you, who had spoken about RPM, and we spoke in length about problems that we face in RPM and hindrances that the patients would face, and from a provider perspective as well. So today, I'm bringing to you one guest that who's going to add the technology wing to all of this. I am proud to present to you the founder of Equipo Health, Parijat Bhattacharjee. Parijat has been pivotal in the healthcare sector for a very long time in the US. He's been working in the healthcare sector for about 20, 25 years now. He's a serial entrepreneur. This is his third venture. He's been working in technology and creating technology in healthcare for a very long time. Prior to technology in healthcare, he has also worked in fintech and consulting in technology, where he's led a lot of MNCs, and he's led the technology and innovations wing in his previous life. So this time, when he's joining us, he's going to bring the perspective around how he has seen technology grow over the years that he's worked in the healthcare industry in the US. So thank you so much, Parijat, for joining us, and thank you, Romanus, and thank you, Rafael, for joining back. And let's start the conversation. In your perspective, Parijat, how has RPM and technology scaled over the past few years? You've been in the industry for 20, 25 years. What's your experience been like?
I believe that the process of a successful solution is defined by three things: people, process, and technology. And I'll explain what it means. When I say people, it means that there has to be acceptance by the receivers of that solution. In this particular case, it would be the patients who would be receiving the benefits of an RPM technology. And the process defines, especially with respect to providers context, how easy it is to implement and how easy it is to scale up. And that requires recognition of the RPM benefits and incentive that it provides, not only the clinical side of things but also the financial aspect of doing and providing those services. And finally, technology, as we all know, is a big enabler. Technology solutions or devices that are used in RPM that have evolved a lot in the last decade. If you look at device companies, they were kind of monolithic in the beginning, focused on capturing the vital signs, but now they are also embracing making it more of a shareable solution where data can be shared. There has been improvement with respect to cellular network as well. So data can be easily accessed and modalities have changed. So even if you don't get data on a real-time basis, you have the option to connect with your devices or your smartphones like Apple or Android devices. So over the last decade or so, there has been a big ramp up in terms of scaling RPM, where all three factors, that means patients are more accepting this as a possibility to improve their wellness and health. Providers are realizing that there is a certain benefit that this can be derived without having a huge burnout. And of course, to support this, there are device companies, manufacturers, and technology that has evolved over the last decade. So it's a very good transition, I would say. And to solidify this, we have seen CMS also reducing some of the barriers and improving the process so that there can be wider acceptance and adoption of this tech.
Right.
Can I jump in?
Yeah, sure, Rafael.
Well, just pivoting off of CMS, right? Between 2019 and 2022, RPM grew 10 times, up to 300 million in claims. So that shows you just the amount that it scaled up to 2022. We're now in 2026. Who knows, quite frankly, the amount of beneficiaries that are actually on RPM. And as Parijat mentioned, I think CMS made an avenue for the most people to benefit and be able to qualify for the service. So RPM isn't as stringent as other services to qualify for.
Oh, okay. Um, yeah, I mean, that's a very positive note, right? I mean, I'm sure it's the same case with other intermediaries or other insurance companies as well. I think there is a positivity that you see in the industry where people are looking at RPM as a predictive analytics tool, for the lack of a better word, but a way for people to see what's going to happen and probably keep people healthy well beforehand. Romanus, anything to add? They've
Yeah, no,
started.
I know.
Note.
Thank you. Parjan and Raphael really touched on it pretty well. And I couldn't help but reflect on Raphael's in our first podcast where we talked about early RPM was hardware driven,
Yeah.
Bluetooth technology and very, very expensive. Raphael, I think you said one device was costing.
We were plugging it right into the phone walls. This is initially that's how we communicated the data, was through an actual landlines.
Yep.
Yeah, right. So there's a lot of that happening, and now, as a lot of us know, it's integrated into many different platforms, and the growth is real, right? You've gone from piloting to partial scale. I would like to say it's in every home out there, but workflow and staffing still limit the true scale, and I think this moment in the next year or two, if not this year, to be honest. The next phase is really about is less about devices and more about better decisions with what the data is showing,
Absolutely.
in my opinion, because I think technology has really hit its limit. I don't want to say technology is limitless, but when it comes to RPM devices, how many times can you get the same reading of a blood pressure, a pulse ox? It's got to lead to something, which I'm sure we'll cover in the next few questions.
Yeah, I
Yeah.
mean, Parijat spoke about people, process, and technology. So somewhere I
Yeah.
think in all of you are saying the technology is there and people and process are there. But I think now we have to think about technology that's going to help drive people and process towards making you're being part of the technology growth that has already been there. Since
Yeah.
you spoke about integration, I don't want to link onto the exact word or the term, but how much do you think, Romanus, that RPM should be separated out, or do you think it should be part of the EMR system? Because this is a topic that I hear a lot in the industry. When I hear when we go to events or conferences or conclaves, this is one question that everybody picks up, and I want to hear what you guys feel. Whether RPM data should be considered as primary data that you use for diagnosis. So, how much of this connection should be there? Should it be independent, or should it be part of the EMR data itself? What do you think, Romanus?
Having been on both sides, on the health system side, traditional EMR, and
Mm.
acute hospital settings, we're not built to handle any RPM type of effort. So when that patient is discharged home, EMR store data. We know that it's
Mm.
one massive database.
Yeah.
RPM drives essentially real decisions when you're getting feedback and that patient's no longer within your eyesight. So I feel that they need to coexist, so that not only is it storing data, but Parjat's team can access that information. Raphael's team can access that information. If they were disparate in any way, that would be another barrier that the clinical teams mainly have to deal with, to know what the historical trend line was, what medications they were on, and how does that translate to that blood pressure that they were started on a new drug on that last admission. How is that reflected now, 5 days into the discharge? I hope that makes sense. Yeah.
Yeah,
Absolutely.
what about you? I mean, what do you think, Rafael?
Right. As much as I would love for everything to live in the EMR, I do believe there's a place for there to be two separate systems. I agree with Romanus. The EMR does hold all of the relevant data, and absolutely the RPM data that's collected that's relevant should be put back into the EMR for the physician's evaluation on their decision making, right? But period, for all of that information to be put into the patient's record, it becomes noise. And I think that it needs to be actionable, it needs to be concise, and it needs to be somewhat summarized for providers So, like Ramana said, once benchmarks are created via plans of care, etc., any fluctuations or changes should be shared. But if the patient's stable, I mean, should you upload 300 readings? I don't think so.
We are speaking about reading. So, Parijat, you are the technologist amongst us. So, what do you think? Because all of this essentially comes on to financials as well and ROI as well. But from a technologist perspective, if do they should they coexist or should they not? Because there's a financial aspect to this which probably a lot of people might not look at. But what do you think?
Yeah, from my perspective, look, EMR is great as a record keeping system. But when we talk about RPM, and it's not just RPM, the other kind of services like chronic care management or behavioral health initiatives or other services, these are for a reason they are called services because these required care coordination effort. And care coordination is a complex process because it's not just patients coming and seeing the physicians or providers at their office setting, but this is a distributed system where the services or the data that we are talking about is collected not only at the physician office but also at the patient's home setting, and that requires multiple things. If you break down the whole care coordination effort, there are different segments. It's not just simply doing alerts management, but there are essential pieces of it, which would be patient activation. How motivated the patient is the motivation level changing over time? Education. Why should I take a reading, or why should I be aware about my A1C, right? Then you need to have uh, processes in place for reporting that data in accuracy. So the it becomes interpretable, and at the same time it's escalated to the providers so they can do some kind of alerts management at the right time, not a week later, not 2 weeks later, but
Exactly.
have to be at almost real time. I won't say real time, but almost real time, right? And then the question that always comes from a business perspective, that we are doing all this effort, where is my analytics? How are you going to tell me that these are the patients I should be tracking more frequently? What's the point of providing this service if at the point of care, when the same patient is in front of me, I do not have a clarity of what has been going in the patient's life when they are in their home setting? So RPM is like a window, or it is to bridge the care continuity gap, which happens at the physician office when care is imparted in episodes. And that's why we call it an encounter, right? Most of the systems call it encounters. So between encounters, whatever is happening, that care continuity can be derived from the RPM data. And since I coming back to the same question that you asked before, that should it reside in the EMR? Yes, it should be integrated with the EMR as an integration or as a supplemental data perspective. But to execute a program successfully for RPM, you need a care coordination layer, which generally is missing from an EMR system.
We've
Yes.
actually all coming back to the first point that Parijat made about process, people, and technology. I mean, we're now still talking about how people layer is really important in making sure all of this is successful, right? And you
Yes.
spoke about 300 data just coming in. Let's say the patient is healthy and there's just data that's been residing, and how much of that is going to be utilized for an analytics that Parijat was speaking about. We really don't know whether it's just data. And that brings me to the next question that I actually had that, and he touched base on it, but I want to hear from you, Romanus and Rafael. Maybe I'll come back to you, Parijat, if you want to add something on. But I wanted to ask, in your perspective, how much of this data is actually useful data or is just being stored, Are you just storing this data, or are these actionable? Are they useful for someone to make a decision on? Who wants to take it up? Rafael, Roman, you're smiling. So
You go
Oh,
first, Raphael.
no, you go, please.
Okay, so
I'll pivot.
this is fresh in my memory. So about last year, every morning as we were trialing a few RPM devices, blood pressure, pulse ox, and scale, and every morning as the director, I had to audit. You know, I had to look at every single no, I was going to call it noise. Every single metric that was measured in the morning. First of all, out of the, I'm making this up here because I don't remember the actual numbers. Out of all the patients that we have active RPM devices on, how many of them who we instructed, every day, like when you wake up, the first hour, check your, sync your device with your vital signs and such. So every day I would see compliance, and then I would look at the the results. So, I don't mean to quantify this, but it's worth saying that out of all of the people, and again, it was high. It was like 30 people, so it was every morning was pretty rough. About maybe 10%. Most data is noise without context, because he wasn't just looking at this morning's assessment. It meant also then looking at, all right, in the last 3 days or 5 days, that was our look back that we had visibility to. Otherwise, I have to set a few filters to see further back. But within 5 days, so look at the morning, then look at 5 days back. Is it still within that safe threshold, or they're normal? So maybe one, I would actually find that someone was outside of that. So less than 10% of it
Yes.
is meaningful information. And in the back of my head, yes, when I review this data, I am looking for a strong signal, right? Like I'm looking for that one patient. And yes, I often found it. But I think if we were to apply some sort of inverse thinking, I think the value of RPM is not how much data you collect, it's how much you can safely ignore. And there's a lot you
Yeah.
can. But again, you got to be cautious about that. Anyway,
okay.
I'm
small
gonna
amount.
go. So
Yes.
I think it's the quality of the data as well. Like he mentioned, right? Having accurate thresholds on your plan of care. For instance, we'll just say my mother. My mother was hypertensive, and we all know, like right now, you want to be under 130 over 80 is kind of like the pre-hypertensive or whatever baseline norm. There's some people that are running 160 over 90 on a normal basis. Romanis, you're the RN, so you can confirm that. And,
Yeah, I
and I'm not
second
going to
that.
say that's healthy,
Yeah,
but
right.
there are some people who normally run that high. If the benchmark or the baseline isn't accurate, you're going to get high readings every single day. Does that necessarily mean that that patient needs immediate attention? Not necessarily, right? So having accurate benchmarks on your plan of care, and going back to like what Parijat mentioned, the people, this is the initial people setting up the patient, educating the patient, and creating the plan of care so that you will live by those guidelines. So if those things aren't set up initially, you can be getting bad data from the beginning.
Makes sense. And I think, Parijat, you would be able to, this when we do check in the data that we receive as part of our platform in Equipo, where we have probably integrated with so many such devices, and we're getting readings. From now, they've spoken from the other side of the story. Let's talk about it from the technology side of the story. Where you are liable essentially to bring out actionable insights from this. How difficult has it been? Because they themselves, being the people who've been running businesses, they are speaking about less than 10%, but they've already analyzed the data that way. So from technology perspective, how are you going to embed this information into, and how is technology changing?
Yeah, so typically, I think I echo what both Romanes and Raphael was mentioning in terms of the quality of data. So when the data is coming from the devices, you can analyze that one singular reading and identify your thresholds. But that's most of the solutions out there is pivoting on. But I think the important thing with RPM is, again, what I mentioned earlier, is to see the bridge the gap between episodes, care continuity. So you should look at the trends. not just look at one singular data. Yes, I'm not saying that singular data should be ignored, but you should see at the trends and see if this is uphill, downhill, or it's just a one-off incident. Possibly the patient who was reporting a higher value than the threshold did not take the reading in the right way, or did not have their medications, or had taken the reading after a long run or a walk. So there could be different conditions that could have resulted into this. So just looking at face value as just one number doesn't really help. Secondly, RPM is also a means to reach out to the patient, because there, as per CMS guidelines, that there are minutes that you can actually bill. Those are care coordination minutes, and they are there for a reason, because that will give you insight to the patient's barriers. What is preventing them from being more diligent about this? You can look at their usage patterns, and then you can extrapolate that maybe in the beginning of the month or during the weekends they are taking the readings, and weekdays they are struggling to take the readings. So understanding those usage patterns also gives you insight without being intrusive. It can help care coordinators to have meaningful conversations with the patients. Are you going to have your medications? I mean, you are missing your medications regularly. That's why we see, differentiated readings over a span of time. So that could be an insight that they can bring it to their team, right? To the care coordination team, and that helps in more meaningful discussions with the patient. And it's kind of a care continuity loop, I would say. If you are just, as a care coordinator, you're outreaching and talking to your patients and say, hey, you did not take this reading, what's happening, and period, that's the conversation.
Yeah.
Then you are just clocking your 20 minutes. That's not the intent of this. The intent of this is to find out what are the barriers and how a care coordinator can bring stability and better quality of life for the patient. And that quality of the life can come when you look at trends, understanding the situation at the patient's lives, and how they are utilizing this program to benefit for themselves. And when you have those kind of personalized discussions, you activate the patient even more, so the stickiness to the program becomes becomes a major factor, I would say.
Can I
Yeah,
can
go
I
Yeah,
ahead.
jump in, Fincy?
I'll go after Raphael real quick.
Yes,
We're
please.
we're social creatures, and period, we want to make connections with other human beings. And RPM is that avenue. As Parijat mentioned, right? Even a complex patient, maybe they go see their physician 6 times a year, maybe, 4 to 6 times, maybe 7. The reality is, right? They're spending, other than working up, etc., they're maybe spending 20 minutes talking to the physician, 25 minutes, right? You add all of this up, within the entire year, the physician actually spends 2.5 hours with the patient, if that. If that, right? And these are complex patients. Patients that aren't as complex, they may get 15 minutes with the doctor, they may get 4 visits. That in itself is 1 hour the entire year. Do you think the doctor has enough information to make the best decisions? And the reality is no. And I love that Parijat keeps pushing continuity of care. These services are meant to basically maintain meaningful relationships with patients, gather data so that you can actually share that back with providers and make the best decisions for patients. So, yes, this is we'll say, clinical type service, but it has a lot of social aspects to it that really drive the value of the program long term.
Yeah. Raphael, that's actually a really quick segue to the times I've seen action taken from RPM data was not only just referencing trends and thresholds in the past. When when a patient had a appointment that was maybe in 2 days or so, what the cardiologists greatly appreciated, even the PCP doctors, was that gathering that information, putting it in a quick PDF, emailing it to the patient, or even to the provider directly, knowing what that threshold was, actually did result in a change in medication diagnosis. And that's what I've seen it most. I think the question was this question of this was about actionable. That's when I've seen it more actionable. I've also seen it in a way where we were the middle person, where we would contact the cardiologist. They would tell our nurse practitioner to change that dose based on the the historical trend of that patient. So I've seen it follow through. It sometimes happens telemedicine wise, or when that patient does see their PCP or cardiologist. It's great to see that balance of
Fincy,
data
Romanus
actually
even
resulting into a change. It's great.
Romanus, you mentioned previously, why are the patients taking their readings in the morning?
Yeah.
It's basically to realize if their medication is lasting throughout the night, right?
Yeah.
Like so it's a stable baseline in the morning when someone wakes up to take
Yep.
the readings. And you explicitly said that, Romanus. Your program, you advocated for people to test in the morning. You would automatically look at the readings in the morning for a reason,
Yeah.
because it directly relates to their medication.
So
Correct.
you see, there's actually two different perspectives to the same part, right? I mean, we're talking about usage patterns, and from a technologist perspective, that's what matters. That's where you would find actionable insights. And you guys are also speaking about people actually having a social pattern, and knowing the social aspect of the patient actually helps. So probably a combination of both would help you get a better, actionable insight. But with technology growing and how educated the patient is about why it is important
Yes.
that they take
Yes.
their RPM reading is really important. But at the same time, if you think about it, Parijat, we have dealt with this in the past where we've had two classes of patients: people who are proactive, so they go into preventive care where they know that this is important for prevention. But we also have seen patients who are being managed who are already having a chronic condition. And somewhere, I don't know, Parijat, maybe you would be able to speak about this better. But I've seen that people who are on the prevent side of the story tends to give better readings than the managed side of the story. Somewhere they kind of know that, I'm not, I don't want to generalize this, but I think that's sort of a pattern as well. I mean, what do you guys think
Can
about
I
it?
just jump in real fast?
Sure,
Look,
sure.
if you're proactive in your health, you're proactive in many other things,
Yeah.
period.
Yeah.
And that is almost how you approach life, right?
Mm.
You're probably proactive in how you go to the grocery store, making lists, etc.
Yeah.
There are people on the opposite side of the spectrum that are not proactive at all and are more reactionary,
Yeah.
period, right? So, unfortunately, I always reference my mother. My mother was more reactionary instead of preventative.
No, most people.
And I think most people are, unfortunately, right? It's like something catastrophic has to happen, and then we open our eyes and change our life instead of knowing exactly where our decisions are going to lead and making a change now. We seem to not do that. So you're absolutely right. Like, to me, there's typically two buckets, and then you wonder, well, why do the proactive people always test within boundaries? They're probably eating better. They're probably taking preventative measures in their own life, while the other person, right? Like, I'll tell you, sometimes just hearing the beep on the blood pressure cuff starting triggers my mind to be scared. And I think my blood pressure rises just from the noises that I hear from the blood pressure cuff. So I actually think patients are conditioned with certain noises and certain different stimulus will actually raise or lower their blood pressure without them even knowing. That's just my thought process, though.
Yeah, I think, well, there is a survey that you can do, and I think it's called patient activation measure, and it defines four different levels. The first level, in plain, simple terms, the level one is essentially that it speaks of my doctor is in charge of my health. So I don't have to do anything. It's my doctor's responsibility to take care of my health. So that's kind of, disengaged and overwhelmed situation. The level two is where you become more involved in a little bit more involved than level one, and you become at least aware, but you still don't have the means to come out of it. So, again, in simple terms, it's that I could be doing more for my health, but I don't know what to do. At least that awareness has built. And level three is where I am taking action and gaining control. That means that I am part of my healthcare team. It's not just my doctor's responsibility and my care team's responsibility, but I am actively and willingly a participant of my care, a participant of my care team, right? And level four, which is maintaining high behaviors and pushing further to say that I am my own health advocate. So RPM, true RPM program should push the levels from level one to at least level three, and in the best case scenario, level four. That means I should be taking action and gaining control of my health. And healthcare is it has lot of the healthcare deals with behavioral stuff, right? Taking your medication, waking up at a certain time, going to for walks, eating healthy. Most of the common chronic conditions. Uh, I'm not a clinician, but a lot of these chronic conditions can be managed well if you make those small changes in your behavior. And that requires activation. That's why I keep saying that this patient activation level is very critical. And RPM can move you to level three, level four, if executed well.
Very important. Speaking about patient activation, I wanted to ask you guys. Well, technologist at heart, I tend to have that dilemma: how much of technology is enough technology? That question always keeps popping in my mind whenever we are creating technology. We kind of start thinking about how much of empathy is needed, especially when we are dealing with healthcare. Other industries also, it's important to know how much of empathy is important, but um, for us, especially since all of us are working in healthcare, it's I think more crucial to understand human versus bot, right? We are speaking about patient activation, we are speaking about usage patterns. So in this context, RPM being something it's still probably evolving, and we in future we expect it to grow really, really to the point that, in your words, Parijat, level four, or patient activation is to the point that the patient feels it's my responsibility and not just my care teams. Um, Human versus bot. How much do you think there's where would you weigh your scale? Would it be towards higher touch care teams, or would it be towards automated nudges where a bot probably just does? And I'll leave it to all three of you to put in weigh in whatever you guys think. But I'm going to put the word agentic AI just so that it does come in your mind.
Yeah.
Who wants to pick it up? This is going to be a fight, I guess, between the technologists.
Okay,
No. Parijat, you go ahead. I'll
I
go
was going
second.
to say that it's a hybrid. It's a hybrid effort.
Yes.
Bots can
Yeah.
reduce the workload for your care teams and your care coordinators, so um, they can offload the routine stuff, to the bots. But care team's role would be, in the new generation's terms, would be more of an influencer. So they can influence the patients to tell that this is why it is important. This is why you should be, tell them about snippets or education or case histories where they have seen successes. You bring that social aspect. If you're a good care coordinator, you should bring that social aspect to say that how others have benefited from this program, rather than you being alone in this, right? So I would say that their role become different than just clinical. They are also social champions, that they can make behavioral change coming back to the previous discussion we were having, they can influence the patients to get activated.
He's used Instagram now. Go ahead, Rafael Romanes.
Um,
I'll go.
yeah,
Romanis,
good.
you're last. You're
Yeah.
the best.
No.
So, right, I agree. There's a hybrid, and it's going to be a little bit of technology, but period, you do need the human interaction. What you're going to think it's funny. I mean, right now your bots are getting better and better, and people are actually saying they're more sympathetic and empathetic. I don't want to say empathetic because they haven't gone through the same things we've gone through as humans. We'll say sympathetic, right? So they're very sympathetic. And I think it's one of those things where when you don't realize you're talking to a bot, you may have more of a meaningful conversation. So, right, like I think younger initiated, we know when we're talking to a bot and it just frustrates us. But when the lines are skewed and you don't know you're necessarily talking to a bot, it can be pretty darn effective, is what we're learning. And I think that will only get better in time. And I think with certain populations, bots may end up being I don't want to say personal attendants, but friends. And they may be the ones, like Parijat said, influencing in a non-pushy manner. It's horrible, but as human beings, we all have tone and diction, and we all, sometimes get frustrated at the smallest things. Bots don't. And right,
Rafael, support technology. I
look,
mean, you're leaning towards technology while
He's
why
crossed
is
over.
it's working. It's working, and people are actually enjoying it. So the point is, like, when people enjoy it, they communicate a little bit more openly. So I do think there's a place for it to grow in the future. You're always going to need the human aspect, though, of it to kind of confirm decisions before they're made.
Romanes?
Yeah. So from my experience, I personally have not introduced bots into the triaging or when patients are discharged from a hospital or a SNF. But having worked at a previous organization and consulting for them, large ACO, we're talking about 50,000 lives in a large health system, talk about 9 hospitals in Houston. They had played an example of a bot calling a patient when they were discharged. And let me tell you, I could not tell the difference. If anything, it was a lot friendlier and a lot nicer. I was just amazed the advancement in technology. It went so well for the ACO that they started introducing it and piloting it for the patients that were non-MSSP lives. So the folks that are being discharged from the hospital, not for everybody, but for those higher risk populations. I admit it took about 5 months for it to kind of tweak because of the legal part of it. Just because this entity had a large ACO and had a large health system. It was interesting how the legal parameters applied to that portion of that population versus those that were discharged from the hospital. I would think it would be similar, but there's just a lot more loopholes to get around from the hospital side. But so what I'm saying there is that automation, triages, humans build that trust and adherence. And I know you touched on this, Fincy. The high risk patients definitely need human touch. Can they be triaged? Sure, they can. But most importantly, even those lower risk patients, I feel that those are the folks that can be automated in some capacity, if that makes sense. But for the most part, the bots were really, really good at triaging the patients that were being discharged very, very well.
Romanes, that's absolutely fine. Romanes, that's absolutely
I
fine.
don't worry.
We work in healthcare and we are people centric, so it's absolutely fine. It's okay, right? So yeah, let's move forward. And okay, so I feel that the balance is then put between Parijat feeling there's more empathy needed, and Rafael, you leading towards technology, and romance is now between the two. But that's a fun place to be, and I'm sitting here thinking, have I like twisted the roles somehow? And I don't know whether the podcast has manipulated you guys enough to think otherwise, but okay.
Yeah,
All right,
we are
so
wondering whether you are an AI bot or not.
Fancy is the AI.
right. So how would you know the difference? But yeah, okay. So let's get to the point where we talk about adoption, right? The adoption of this entirety of RPM on the whole. I know this might go into any it can be this can be a question asked for anything that we do in healthcare and care conversations. The podcast that we are in, we are trying to demystify theories that we have heard in healthcare. So it's only fair that we ask that question. Where is it more difficult in terms of adoption? How has the adoption been all these years, and where is it more difficult? Would it be Parijat, in your perspective, integrating with EMRs, or Rafael Romanes selling the concept to providers, or whether for all three of you, whether proving the ROI? I'm gonna probably start off with Rafael. You talking to us about where has the adoption process been? How has it been in the past few years, and where is it currently, and where do you think this is going?
So, right, as I mentioned before, the 10x growth, there's over 500,000 Medicare enrollees currently on RPM, right? My number one thing is as we scale, there's obviously going to be fraud, right? And that is something that CMS has actually mentioned for the last few years is the prevalence of fraud in the program. I apologize. I'm kind of going off on another subject.
No, yeah, but yeah, that's a topic that I think I had in my bucket list to pick up in as it is as regulations and but yeah, please go ahead.
Well, I'm sorry. I kind of lost track of the questions. Explain the question one more time. I'm sorry.
I was speaking to you about where it is more difficult in probably taking into account the US
Oh,
health system.
that,
You know,
that's what I was going to say. I apologize. Is right. 10 years ago, it was selling it to the providers as the most difficult thing. Now, with the prevalence of fraud, I think it's actually convincing providers that you're doing things the right way and that your program is ethical and that it's going to bring meaningful value to their organization to make that investment. So that's where I was going with the fraud. I apologize. It's been so prevalent that now providers are actually, they've either been burned or put in a situation where their license could be in jeopardy, all because a third party program wants to scale and have hundreds of enrolled members, when we know and we've said from the beginning this should be very strategic and it should be cohorts, high risk cohorts that can really draw value from the program, right? So my whole view on the abuse and the prevalence of fraud is actually pushing providers away from actually utilizing and expanding the program. So that's my barrier. It used to be, oh, getting providers to understand the value. Well, then they saw the value, they adopted it, it kind of got out of hand. And now it's finding, the right ethical partner that understands the goals of not only the provider and the patient, but how are we going to bring a better quality of life for that patient together?
completely agree. That's something that over time we would get to understand when we, as adoption increases. Romanas, what do you think? How's the adoption process been in the US? If you take
Yeah.
take into account, maybe proving ROI,
Yeah.
or case of providers.
Yeah, that's the thing. Whenever there's a new product that's been introduced either to the health system or a large practice or a specialist group, it's always
Right.
looked at as, okay, how much work do I have to do? How much of it, because I've got my
Yeah.
8 hours, if not longer, in the office. How much work is going to extend further out? Do I need to get a team involved? Let's be honest, RPM is not going to seamlessly just put itself together. To Parjat's point earlier, people, process, technology matters the most. And unfortunately, most of the conversations always start with ROI. And this is one of these things where there's no unless Raphael knows, there's no ROI calculator in the world that's going to magically show outcomes immediately. It requires the benefits of RPM do accrue over time, not immediately.
True.
Yeah, it's a hard sell as long as you see the value, knowing that you don't have to stop seeing your patients when you see them turn around and walk out your office door, and knowing that you can keep tabs on them, or you've got a team that does, that can always keep you informed of their disease process or their condition. Is that declining? Because you have this gut feeling that I wish I could do more. Well, what are you going to do? You're going to send them to the hospital to get put in observation status? Know that they're not going to meet inpatient admission criteria, so they'll be discharged. And do you think the patient really wants to go to the emergency room to get evaluated? So it fits in that middle line. We're like, all right, if they go home, how do I know they'll be okay? And this is where RPM with the right people and process in place will help kind of, you got to feel it in you. If you're coming in with ROI as your first thing you want to see out of this, which I get it, you do, everybody does, but it's not going to happen overnight. May not even happen this quarter.
Yeah, I think I would add to that is the biggest fallacy is you cannot implement RPM by buying, a good lot of devices. I have 100 devices and let's just do RPM program. No, it doesn't work that way, right? Because every practice, every provider patient relationship is different. And you need to, as a service provider, you need to, like, I can speak on behalf of Equipo as a service provider, as a services company, not a provider company. A services company, Equipo needs to understand the DNA of that particular practice and how it is run. So there may be different patient mix, there could be language barriers, there could be apprehension about technology. There could be a doctor feel that, no, this is not for my patients because my patients are not tech savvy. So it's a process, like Romanas was saying, it's a process. It needs education, it needs reconfirmation to say that this is really going to benefit, and to not just impose, like, here are your 100 devices, go out, implement, and you would certainly see $20,000 in increment in your billing. It doesn't work like that.
No. Can I jump in, Fincy? I just want to drive Parijat's his statement: people, process, technology. Look, we have the technology, we have the process. It takes people to execute. I've helped several home health organizations, health systems implement and create remote patient monitoring programs. I don't want to say that this is due to me, but a large majority of them fail, right? People think, oh, I'm just going to give somebody a device, I'm just going to activate a program and it's going to magically work. That does not happen ever, right? Within, like Parijat was saying, within the practice, the service has to be communicated with everybody. When a patient calls and the front desk person picks up and they're talking about their equipment and they have no idea what RPM is, you just did the patient a disservice. You just did the program a disservice, because you actually, now the program hasn't been validated in the eyes of the patient and they're not going to participate because it doesn't seem meaningful. Everybody within the practice or within the organization needs to understand why you're executing the program, how it plays a role in their decision making or their day-to-day activities. But where I've seen these programs fail is when there is not communication amongst all stakeholders. So, you can have the best technology. I've been in organizations where they buy 500 sets of equipment. They say there's no turning back. We're buying the equipment. And then it just sits there, tens of thousands of dollars, never executed, never even used, because it takes much more than that, right? The program, there has to be more meaning in the program. And if you're looking at just ROI, like Romanes kind of implied with me, there isn't a very simplistic formula for that. How is RPM helping? Hey, well, maybe on my triple weighted medication management adherence for my MA plans, It's helping me move up my star rating. I need to touch my high risk patients on my MA plan, so it's helping me on my star rating there. Oh yeah, CAP surveys are also a direct correlation with patients, satisfaction. If I'm contacting them, developing relationships, they're going to speak highly of the organization. It's hard to quantify all of these things, right? But all of them play into your star score, which ultimately helps with incentives, or back on the ACO side is going to help with your shared savings. So it's hard to say tit for tat, I reduce this many rehospitalizations or admissions. You can make assumptions based on the past, but the reality is it's really hard to put your hands around these numbers. But they
Agree.
do drive value. And I think they drive more value than people realize, these services, because they touch so many other aspects of the patient, the care continuum, as well as the value based contract that they're trying to execute.
No, I completely agree. I mean, they think of it this way, right? I mean, you can't have, there are different characteristics of the patient that you also have to take into account. This is not something that can immediately give you results, because the process and what Parijat was speaking about, the process does not end with you being able to activate a patient or, get the patient to start being part of the program. It's a continuity, right? So the process continues till you see results, and sometimes, you get actionable insights only year later, or it's probably, there might be nothing to quantify till a certain point in time. But people people like Parijat and I, who work on data to create AI or technology around that, we know the importance of having continuous data, even if it does not give you insights today. The characteristics and patterns that we can recognize from these patients and their characteristics will help for future preventions as well. All right, so I'm coming towards the end of the podcast, where I do the fun part, which Rafael and Romanas was part of last time, which is my fun little rapid fire. So, Parja, I did not give you the questions because I knew you would get prepared for this. But this is now going to give you one. I'm going to give you a statement. I want to give me yes or no's, or maybe a couple of sentences. I don't need explanation.
Yes
I'm
or
going
no?
to start with Parja, that I think I know the answer to this, but I'm still going to ask it. Will big techs like Apple, dominate RPM? Yes or no?
No.
Don't think. Okay, thank God. I kind of thought you were thinking for a second. You're going to say no. Do you want to substantiate it
Yeah,
a little bit?
no. From a wearable tech, yes, because that's part of Apple's ecosystem and their agenda moving forward. But that the reason I said no is because, like, I still believe that it, from a clinical perspective, at least not in the consumer space, but in the clinical space, it requires human intervention and appreciation for care coordination.
Okay. Um, just before you guys give me your answers, I'm giving you 2 minutes to think, but I wanted to add to our listeners, people who are watching this, is there's a thin line between being an RPM device and being a wearable. Not all wearables are RPM devices. So I know we spoke about this at length during our previous episode, but I still
Yes.
wanted to make sure that clip is here, where people do listen to that part. I put an emphasis enough on people understanding the difference between a wearable and an RPM device. But Rafael, to you, the same question. Do you think big techs like Apple are going to dominate RPM?
Um, I agree with Parijat. Like it's gonna dominate wearables, but it's executed at a physician or a practice level. So period. I just don't think, unless they start purchasing clinics, and I'm not gonna say that's outside of Apple's scope, but until they start working with PCPs directly, I just don't think they're gonna be the growth factor.
Why are you giving them ideas as if they didn't have?
I know.
Then why are you giving them ideas, Rafael? Romanus, over to you. What do you think?
Yeah, I'm going to agree with Parja and Raphael as well. They'll own the data capture because of their ecosystem. It is vast, and the devices and the engagement layers, but they will not own care delivery. That is definitely very much a clinical workflow. Now I get it. You've got a younger population that could easily turn every part of that device on to better capture, but still, it's got to go somewhere, right? Now,
Yes.
so it's definitely not. I'll be honest with you. If they did, they'd have dominated a long time ago.
Exactly.
In my opinion,
They all tried.
yeah.
And they've all tried and failed, right?
Yeah. So they'll be the front door. Absolutely. They're in every home, but the care team's still going to be there for the workflow stuff. Yeah.
Would it be a single word? Not a yes or no, but biggest hidden risk in RPM. Rafael, you go first this time.
I'm going to just say fraud.
You are stuck there. I think the next episode will be
I'm tired of Look, I've been in RPM since 2013. I've been an advocate on a state level in several different capacities. There's always people trying to get rich quick. I'm sorry, there is. And it ends up damaging the reputation of the program for the people who are actually trying to execute it properly and actually take care of patients and elevate physicians. So fraud is the one word that I think could hurt the program.
Menace, what about you? It's very strong.
Yeah.
What about you?
Man, I've got three. I'm gonna maybe part. Yeah.
Let me pick first.
Yeah, it's hard. I will make it one long sentence. I'll jump it's the first thing as a clinician is alert fatigue. I don't need another device telling me all of this noise, right? I'm gonna cheat, Parijat. I have a feeling you will cover these two. Workflow burden, which is kind of alert fatigue. It's a symptom of it. And false reassurance. I'll be monitoring without intervention does create a ton of blind spots.
Yep.
Just my opinion. So this is why it's hard to do one. That is power packed.
Gone against technology. Now you tell us what's the biggest hidden risk.
Well, they touched two different aspects, but they probably didn't touch the patient side of things. I think it's adherence. I think it's adherence. When I say adherence, is as a patient, just like Romanus is talking about clinical fatigue, it can be a patient fatigue too.
That's great one.
Because I am using this device and every morning I have to take my reading because I have been told I want it to be seamless. I don't want somebody to poke me and tell me what to do. So adherence, that's why I said it's not from it's CMS definition of adherence of X number of readings. I'm just saying that my adherence to the program, that I have to do this, it's again a behavioral change, but it can become overwhelming.
I'm going to jump in real
That was
fast.
going to be my fourth thing, but Parijat, I was saved it.
You lost it.
I agree with Parijat.
I don't understand. Go ahead, Rafin.
So on Parijat's statement, so CMS introduced a new billable code for RPM from 1 to 15 readings. So to kind of combat that fatigue, at least the provider is now being incentivized for having that device and having minimal tests as opposed to 16 or more readings just to get paid for that actual hardware. So the reality is, I think CMS is coming to the realization as well that we got to crawl before we walk or run. So expecting patients to test, at a very high rate per month didn't really push, I think, results. And I think we've kind of implemented a little bit of leniency with the new code.
Man, if you want to go with your fourth one, this is the last time that I do that in
I know. No, Parijat took my fourth one. No, nothing to add. I think we covered it pretty well. Yeah.
Okay, Romana, so the last question probably goes first to you, and that's this is a yes or no question. I want to know, trust AI for triage, yes or no?
For triage, yeah. You know what? Yes, with a ton of guardrails. Again, that ACO adoption was very, very quick. On the health system side, still a big company, 5-6 months sitting on legal. And the guardrail stuff, it's really like, what questions is the AI asking? And what if the answer is outside of the norm? Will that triage a signal for an RN to call that patient? So yes, with guardrails, just like everything else.
Oh, okay. Parijat?
Yes.
I mean, how would you expect you to say? How I expected you to say no? I don't know why. Raphael, what about you?
I'm with them. Yes,
Oh,
guardrails,
okay.
guardrails.
Okay. All right. So I think we are all looking at the same thing. I mean, we build AI on a daily basis, so we understand how important it is to have the guardrails. But I agree. I mean, AI has grown to the point where you can have it speak about weather
Yeah.
and climate and seasons and all of that while you're talking with the patient. So you will have to remove the noise as much as you can to make it more meaningful data. But I think you should be able to use it for triages. All right, so that brings us to the end of this episode of Care Conversations. I had three wonderful people with me. Parijat, thank you for joining us. I know you couldn't join us last time. I think the caption to this episode is going to be People Process Technology. You just coined that term, and I don't know how many times we used it. And thank you, Rafael Romanes. You guys have been wonderful. The last two episodes, we spoke a lot about RPM. We are going to segue into other conversations because, as promised, we are not going to limit to certain topics. We want to demystify theories that people have heard about healthcare, and we want to bring a lot more pathfinders, people who have revolutionized healthcare in the US. I had three wonderful people with me for past two episodes. I'm going to bring more people to you. So thank you so much, guys, for being part of Care Conversations. Team up with Equipo. Let's simplify healthcare together. Thank you.
Thank you.
Thank you, guys.
Thank you for hosting us.